Hi, my name is Jonathan Schapiro. I'm from the National Hemophilia Center at Sheba Medical Center in Tel Aviv, and I'll review some of the CROI data regarding COVID-19 and HIV. And I'd like to start by apologizing to all the excellent studies which we won't have time to touch on, but perhaps you can bring them up during the discussion. So let's speak a little bit about the interplay between COVID-19 and HIV. And I'm going to be referencing extensively a wonderful presentation from Julia de Amo from Spain, who gave a wonderful overview, and start looking at how HIV impacts COVID testing, susceptibility, and severity. So first of all, are people with HIV tested more frequently for SARS-CoV-2? These are data from the United States, a wonderful study presented by Park and colleagues from the VA. And the VA is a very nice source of information, since it's one system with very similar patients, and the only difference is those with and without HIV. So a very good control. And we see here those in red with HIV, and then those in blue uninfected. There's actually more testing going on. Therefore, veterans actually with HIV were tested more frequently. And perhaps this isn't surprising. In general, patients with HIV are often already linked to care and receiving care. Perhaps heightened concern for symptoms, both by the clinician and the patient, and maybe other factors, but perhaps not surprising that HIV-infected patients are tested more frequently. But what about a higher risk of actually being infected? And we have quite a few studies. I'll just touch on some. From the same VA cohort, actually, you can see here that the prevalence was no difference, actually, of positive COVID tests. And a study also from New York, again, showing that it was not different than you'd expect from the prevalence of HIV in the population. And we see another study from New York, where at first it would seem that the rate is higher at 1.43, but after you standardize it, you see actually that it's not increased, that it was the same for people with HIV. And just one issue that came up in data from Spain was this tendency of patients receiving Truvada, receiving tenofovir triacidabine, to have lower prevalence of COVID, and we'll touch on this as well. But the question really is, are we seeing sometimes more COVID positivity because of the HIV, or socioeconomic vulnerability of the population of patients who tend to have HIV? And this was covered very nice in the presentation. So this higher social susceptibility to SARS-CoV-2 due to the risk factors that are more common in people with HIV, such as racial ethnic minorities, poor and crowded housing, neighborhoods with intense transmission, occupation, sex practices. All these put people at risk, not because they have HIV, because they're characteristics of people with HIV. And as was pointed out now, perhaps there were factors such as receiving Truvada, which could reduce it. And what about outcomes? So will people with HIV, if they are infected, have more severe outcomes? There was a lot of great data. And I think, it's plausible that we would see more. HIV is some degree of immunodeficiency, and we know that immune deficiency is a risk in these viral infections for more severe outcomes. But that higher prevalence of comorbidities, hypertension, diabetes, COPD, renal disease that we see more frequently in HIV-infected patients, these too result in more severe outcomes. And it could be not the HIV, but these factors that would contribute to more severe outcomes. And the additional one is accelerated aging. We're learning a lot in recent years about HIV and aging, and it appears that to some degree people with HIV have a more advanced biological aging, and the connection between severe outcomes and age is so strong for COVID-19, this could be another driver. But there were some thoughts that perhaps you'd actually have better outcomes. Immune dysfunction leading to mild inflammation maybe could dampen that inflammatory response, which is responsible for much of the pathology of COVID-19. So perhaps the fact that someone is HIV positive, they won't have a great immune response. This is a little bit problematic. since we know that immune modulators have to be administered later, not in the early viral phase. And of course, for HIV, this would always be present. So that would be a little problematic. And as we mentioned, antivirals, although there was the thought that perhaps lovinavir or ritonavir would have this quality, and it was proven not to, I think on tenofovir, we're still debating it to some degree. So what does some of the data show? Here's a great large US study. And you can see the first thing they saw is, of course, this bias, is that patients actually, people with HIV tend to be from specific ethnic groups, such as blacks, who we know have worse COVID outcomes. And of course, here are those comorbidities like diabetes you can see. So not the HIV disease itself, but these characteristics. And you can see before matching, there were greater differences in mortality and inpatient services. And after the matching, these remain, but for mortality, you can see it's getting very close. Another study, once again, data from New York, and you can see that the ratio is actually quite large, but after you standardize for the confounders, it gets much, much smaller. And finally, from the original study we mentioned by Park and colleagues from the VA, when they looked at this populations that were so similar in the VA, they actually didn't find higher rates for hospitalizations, ICU admission, intubation, or death. And finally, a study looking at solid organ and HIV transplants, once again, from the United States. We can see here that for those with HIV alone, although the crude estimate looked large, when you actually corrected here, you got very small increases, and this was presented by Jing Sun from Johns Hopkins. And a study from the United Kingdom, Ming Lee presented this from Guy and St. Thomas in London. And they tried to adjust here. They adjusted for the mean age and the gender between HIV positive and negative. And they were looking at clinical outcomes of hospitalized patients, but they did find there were differences. For example, fragility score was higher on the HIV patients. And if you look on the left, looking at the time to improvement or discharge, it lagged behind in HIV-infected patients, although as you see on the right, there was no difference in mortality. So we saw plausible reasons why you would see an increase and why you might not see it. I think from the data we've seen so far that some studies do show an increase for severe COVID outcomes in people with HIV, although much of this appears to be due to the characteristics of the patients, such as the comorbidities. Now, the degree that the HIV itself is contributing, there may be a contribution, although I think it's not entirely clear and the magnitude is not clear. But we have to keep in mind we're looking at HIV patients as a group. And the degree that they may have more severe outcomes may depend, first of all, on the specific patient and also perhaps the setting that these patients are being treated. This is a wonderful study from South Africa, from the Western Cape. Very large number of HIV-infected patients and cases, very meticulous study. And here in South Africa, this patient population with these healthcare services, after adjusting, they still had a substantial increase. So perhaps the studies we saw before from the States and England will give a different results from the patients and the state of South Africa. In addition, perhaps the patient population, their degree of immune suppression from the HIV will vary. Here, they did try, Viscara, look at differences we see at the bottom in CD4 counts. The numbers are small, and those with less than 200, perhaps there was a little trend here, but it was hard to see. In a larger study, we mentioned this study before from New York, they did divide this up into patients with different levels of immune suppression. I think you're not seeing here the unadjusted in hospital because of the picture, but if you look at the slides, you'll see there does seem to be a trend for worst outcomes as CD4 gets lower. It's barely noticeable, but perhaps this is not the cutoffs we should use. I'm thinking if you looked at patients perhaps with CD4s of less than 50 and more than 500, maybe we would see differences. Or maybe other parameters. What about CD4 to CD8 ratio? I would be interested to see data if patients who have a ratio of less than a half and more than one, maybe there we would see very different impacts on the severity of COVID infection. And as I mentioned before, Julia Del Amo did mention that the issue with tenofovir is still not resolved. There were studies showing a benefit. There is some biological plausibility, although it's not a classic drug that we would use for this. And there are actually now ongoing trials. And during the discussion, we'd be happy to hear comments from the audience, your thoughts on this and your experience. Let's shift gears now on the interplay and look at a bit, how did the COVID-19 pandemic impact our care of treatment? There was again a wonderful Andrew Kambugu from Makerere in Uganda did a great study. I'll just touch on two studies. This is a modeling study looking at the impact of COVID-19. They looked here actually at a number of different models in this study by Jewel. It's been presented looking at different factors. So what are the different things that could impact condom availability for prevention, our overstretched systems where maybe the HIV docs are moving to COVID, but what they saw did really stand out with ART interruption. In the model, what had the biggest effect was if there was a lack of supply of our antiretroviral drugs to patients. And here's another very nice study where we also, by Hogan and colleagues, that modeled the impact of COVID-19 pandemic on a number of diseases, on HIV, tuberculosis, malaria in low and middle income countries. And beautiful study. Let me just highlight for HIV. This is country setting 1, which are very high rates of HIV. And you can see by this elevation, the increased mortality you would get over time. But the blue is no action. But we can see on how the pandemic is treated and how we try to mitigate this, we can actually reduce this greatly, depending on how well we do. So I think pandemics, and I think we can use this for other major disruptions, natural disaster, military conflicts, can substantially impact HIV treatment and prevention, and identifying which interventions will have the greatest impact and minimize these disruptions is very important for us, not only now, but for the future. And we should allocate resources to prepare and deal with these if it happens again. And finally, on disparities in COVID-19, we know that there are disparities on race and ethnicity, among others. And this is a wonderful, large study from the United States. Jessica Islam from the University of North Carolina, from a very large database, looked at these disparities. And you can see odds ratio for non-Hispanic Blacks, Hispanic or non-Hispanic Asians in the United States is substantially more than for whites. And there are other studies, I think, which confirm this. And last, I'd like to show you data from Switzerland, which I think is very important, since Switzerland is an example of a relatively wealthy country where there are great resources dedicated for the whole country to get universal coverage and excellent health care. And this results in two things. One, they have very good health care for everyone in the country, but also great data, since all the data can then be collected nationally. I want to take a few minutes to familiarize you with what they have here. They have this SEP, which is socioeconomic position. They actually divided the country up into very small units, small neighborhoods, and looked at people's socioeconomic position, and they have deciles going from 1 to 10. So are you in the lowest 10%, next 10%, and you can go, the lowest is red and the highest is green. So if you're better to do, better educated, you'll be in a green neighborhood, and if you're lower, red. And they looked here at the whole map of Switzerland. Look here on the left. Now, if we look here and we see Lake Geneva, and we can see that living along the lake, Lausanne, Geneva, these wonderful communities, it's very green, saying that people have a very high socioeconomic position. And if we look now on the right side, and this is life expectancy, and we can see again, it goes from the purple, which is the lowest, to the yellow, that's the highest. We see a lot of yellow around Lake Geneva, saying that people from higher socioeconomic positions have a longer life expectancy. And if you look when we go far away from the cities to more rural areas, we see more red, so a lower SEP. and again, a lower life expectancy. So these are very good, tight data, and we had the pleasure of Julian Roy from the University of Bern presenting data regarding COVID. And we can see here, it's a huge database. You look here, the numbers of tests, positive tests, hospitalizations, ICU admissions, deaths, a very, very large and comprehensive database for the country. And what they did here is they looked for each decile, how they did in tests, positive tests, hospitalizations, ICU admissions, and death. And they have here three denominators. The top is a general population, tests performed, and the lowest one is positive tests. I hope you can see that with on the slide. And they looked for each of these outcomes, how it divided up between the socioeconomic position of the population. So if you look at the top, we see who gets tested more, which decile got tested more, and you can see here those that were richer. So the wealthy had more tests, and who actually had more positive tests? Those from the lower socioeconomic position. And if so, who were hospitalized more? Again, those from the lower, and ICU admissions, once again, the poor people. And looking altogether, who had the lowest rates of death from COVID? It were those with the most money. And this is, again, a wonderful comprehensive database. They also looked and looked for adjustments, and they found their data were very, very consistent. So people with lower socioeconomic position in Switzerland were less likely to get tested, but more likely to test positive, get hospitalized, and be admitted to the ICU, and a tendency to higher mortality. And possible interpretation that some of these are mine. I think this is important because this is a country with such good health care. Even when there's universal health care, there are probably differences. Your access to great doctors in a major hospital are different if you're living in Geneva or far away. But there's another level here. I think secondary to being in a lower socioeconomic position, even if you're given access to good health care, you won't be able to avoid detrimental outcomes from the pandemic because your jobs will have a higher exposure to infection. You'll have more comorbidities. And I think education can have a big deal. I think if you're not as well educated, you will not be able to choose your job, but perhaps your choices regarding healthy living and your lifestyles will also not be as good. And I think if we want to really arm our populations to get the best care, it's not only giving money for universal health care, but also increasing perhaps education for everyone. So I'll stop here and thank all the presenters and the data and hand it back to Anton. Thank you.